Our presentation today is about meningitis. Meningitis is an inflammation of the membranes that surround the brain and the spinal cord.
Meningitis can be caused by infectious or non-infectious agents. Infectious agents as bacterial, viral, fungal, or TB. Non-infectious as non-steroidal anti-inflammatory drugs or brain surgery, head injury, lupus, or cancer.
In neonates, meningitis is mainly caused by Listeria monocytogenes, Escherichia coli, group B streptococci.
In infants, by Streptococcus pneumonia, Haemophilus influenza, Neisseria meningitidis.
In children, by Neisseria meningitis, Streptococcus pneumonia.
In adults, by Cryptococci, Mycobacteria, Neisseria meningitidis, and Streptococcus pneumonia. The viral meningitis occurs mostly in children younger than age 5, in contrast to bacterial meningitis that occurs in preteens and young adults.
Mostly between college students living in dormitories, military personnel, and children in child care facilities. Pregnant women are at an increased risk of catching listeriosis.
Now, the sequential steps that allows the pathogen to reach the meninges.
Nasopharyngeal colonization, then nasopharyngeal epithelial cell invasion, then bloodstream invasion with bacteremia, then it crosses the blood-brain barrier and enters into the CSF, where survival and replication occurs.
Bacterial meningitis almost never result from simply being in the same room or building with someone who has meningitis. They spread through direct contact with respiratory secretions. This means that it can be passed to someone who kisses an infected person, or to someone who touches the secretions from someone who is sneezing or coughing and then touches his or her own nose or mouth.
The signs and symptoms of meningitis: fever, headache, stiff neck and back, photophobia, abnormal sleepiness, confusion, vomiting. Infant symptoms are not as specific as those in older children and adults, but usually include lethargy, poor feeding, crying when moved, and vomiting. Infant may not have neck or back stiffness while ill with meningitis. Meningococcus can cause a reddish purple rash that rapidly spreads over the body.
Complications that can be caused by meningitis: permanent learning disabilities and other brain damage, seizures, abscesses, myocarditis, shock, hydrocephalus, sepsis, deafness, organ failure such as kidney, and death. Complications can occur rapidly and be severe, even with quick diagnosis and treatment of the disease. Up to 15% of meningococcus meningitis are fatal. Long-term effects are seen in about 10% of those who survive bacterial meningitis.
In a clinical diagnosis, we can do more than one test as 1. Kerning sign. It's positive if pain in the lower back or posterior thigh occurs when knee is extended while the patient is lying in the supine position and the hip is flexed at a right angle. Brudzinski sign. It's positive if knee and hip flexion occurs when the neck is flexed while the patient is in the supine position. Glass test. Press the side of the glass tumbler against the rash. If the rash does not disappear, then it's a symptom of meningitis.
In lab diagnosis, first we perform a lumbar puncture for CSF analysis, which distinguish between viral and bacterial meningitis. In bacterial meningitis, the white blood cells count is more than 1,000. Neutrophils more than 50. Glucose is less than 30 mg per deciliter. Proteins are more than 100, and red blood cells from 0 to 10.
In contrast to viral meningitis, in which white blood cell count is from 100 to 500, neutrophils less than 40, glucose less than 30 to 70 mg per deciliter, proteins from 50 to 100, red blood cell from 0 to 2.
And we can do another test as blood test, chest X-ray, and CT scan or MRI to confirm meningitis. Treatment of meningitis: if it's caused by Streptococcus pneumonia, we can treat it with penicillin G or ampicillin or vancomycin with third-generation cephalosporins for 2 weeks.
If it is Neisseria meningitis, we can treat it with penicillin G or third-generation cephalosporins for 7 days.
If it's Haemophilus influenza, we can treat it with third-generation cephalosporins for 7 days.
If it's Listeria monocytogenes, we can treat it with ampicillin or penicillin G for 3 weeks.
If it's Escherichia coli, we can treat it with third-generation cephalosporins for 2 weeks.
If it's group B streptococci, we can treat it with ampicillin or penicillin G for 3 weeks.
Cases of bacterial meningitis should be reported to state or local health authorities so that they can follow and treat close contacts of patients and recognize outbreaks. Travelers should receive a vaccine if they are traveling to epidemic areas. For the prevention of meningitis, we can use several vaccines as for Haemophilus influenza there is Haemophilus influenza type B vaccine.
For Streptococcus pneumonia, we can use pneumococcal conjugate vaccine or pneumococcal polysaccharide vaccine.
For Neisseria meningitidis, we can use meningococcal conjugate vaccine. For chemoprophylaxis, rifampin is given to family members of an infected person to reduce the risk of contracting the disease, because most of them, as Haemophilus influenza, can persist in the nasopharyngeal secretions even after successful treatment.
Pregnant women should not take rifampin as it may harm the fetus. They should be treated with single doses of ciprofloxacin, azithromycin, or ceftriaxone. Prepared by
Sarah Sa'a.
Dina Mohsen.
Supervised by
Dr. Abdulraouf Al-Manam.